In the last part, we looked at one aspect of our fragile moral consensus, the idea that patients have the right to refuse treatment, even life-sustaining treatment. In this part of the presentation, we're looking at a slightly different issue, and that is the idea that it is sometimes perfectly morally legitimate to refuse such treatment, that it makes moral sense to refuse such treatment, or for us not to provide it when we are having to make decisions for patients. Let's look at those ideas now. While the considerations we looked at in the previous presentation related to the idea that patients have a right to refuse treatment, it is also important to recognize why many of us, including medical ethicists, have come to the conclusion that refusing a life-sustaining treatment or not providing it is sometimes completely morally permissible. What's the basis for that recognition of the permissibility of withholding life-sustaining treatment? First, I think it's grounded in a recognition of the inevitability of death. As much as we would like to believe that we can live forever, in fact, we know that we cannot and do not. And sometimes what is best may be simply to stop the fight against that which is inevitable. Of course, that suggests the second point here, a recognition that biological life, simply being alive, is not the only value to be considered, and is certainly not an absolute one. Yes, life is a value, but quality of life considerations may lead us to the conclusion that sometimes we are better off to die sooner rather than later, because the quality of life that we are experiencing is so diminished. And a final consideration here, of course, is a recognition that many life-sustaining treatments are incredibly burdensome. The side effects of chemotherapy, for example, the violence and the injury that often results from cardiopulmonary resuscitation, the interference with normal human functioning that a breathing tube may cause. And not to forget as well the costliness of such procedures, which may often force a patient's family into bankruptcy. All of those things are legitimate burdens that have helped to lead to our recognition that sometimes refusing or not providing a life-sustaining treatment is perfectly justifiable. So what are some of the things that to think about when trying to decide whether it's okay to refuse or to withdraw treatment? Obviously, when the patient has a terminal illness from which they will not recover, we are more likely to think that withholding or withdrawing life-sustaining treatment is perfectly permissible. When the patient is already in the process of dying, and when that death is imminent, no matter what we do, they will die relatively quickly. Obviously, when pain and suffering are great, and all of our best efforts at pain management have been unsuccessful, we may be in a situation in which it is appropriate to withdraw treatment. And of course, there is that consideration of the quality of life. When the life that is sustained is one that hardly involves the sort of experiences that make life worth living, then quality of life may be so low that sustaining life is hardly a benefit. I want you to pay particular attention to the last statement here, that when treatment is extraordinary rather than ordinary, we may think it appropriate to withhold that treatment. The problem, of course, is figuring out exactly what that distinction means, and unfortunately, it's a somewhat confusing distinction. I think we would normally interpret it to mean that a treatment that is unusual, is highly invasive, involves a lot of technology, is costly, that's extraordinary. Whereas an ordinary treatment is one that's been around for a long time, it's not terribly expensive, it's one with which we are familiar. But the obvious question is, what has any of that to do with whether or not the treatment should be provided or not? Notice this passage, again from the Council of Ethical and Judicial Affairs of the AMA. It begins looking at sort of that ordinary meaning of the distinction between ordinary and extraordinary. It says criteria for making the distinction include customariness, naturalness, complexity, expense, invasiveness, and balance of likely benefits versus burdens of the particular treatment. But then focus on this statement. The ethical significance of all these criteria are essentially are subsumed by the last criterion, the balance of likely benefits and burdens. Okay, this is what I want to make sure that you understand. That when you hear this language of, we don't have to provide extraordinary treatment, only ordinary treatment, I want you to think about benefits and burdens and balancing benefits and burdens. That's the only thing that matters. Any treatment, given the context, might be extraordinary, and any treatment, no matter how invasive, no matter how technologically sophisticated, no matter how expensive, might in fact be an ordinary treatment in the particular medical context. The issue is the balance of benefits and burdens. So think of it this way. An ordinary treatment is a medical intervention whose benefits to the patient clearly outweigh its burdens. And by contrast, an extraordinary treatment is one in which the intervention has burdens to the patient that outweigh whatever benefits it might have. And the key point here morally is that extraordinary treatment that does more harm than good, is generally considered optional. Non-treatment is considered morally permissible, even when among the benefits of that treatment is the sustenance or sustaining of life. Ordinary treatment where the benefits clearly outweigh the burdens, is considered mandatory, and it would be wrong to refuse it and reasonable to question whether you ought to provide it even when the patient is refusing it. So the key idea here in terms of deciding what treatments are obligatory and which may in fact be removed or withheld is this balance of benefits and burdens. Where the treatment is beneficial or more beneficial than burdensome, we ought to provide it. Where it is more burdensome than beneficial, even if it extends life, it would be okay to withhold it. Okay, so what are the potential benefits of any medical treatment? Obviously, the greatest possible benefit is that it reverses our disease process. It heals us or cures us. That's the best thing any medical intervention can do. But another benefit is that it extends life. It's a life-sustaining treatment, whether or not it cures us or heals us. And then finally, one of the benefits of medical interventions are that they alleviate suffering, what's called a palliative treatment. So those are the potential benefits of treatment. Now, of course, what this distinction between ordinary and extraordinary requires us to do is consider those benefits over against the possible burdens. What are the burdens that are involved in any medical intervention? Well, it potentially harms the patient's physical condition. It has what we call side effects. We gave you this medicine, we did this intervention because we wanted to fix or address this. But one of its side effects was that it did this damage. Among those negative side effects are often pain and suffering. We're obviously not doing this for the intention of increasing your pain and suffering, but obviously medical interventions are often accompanied by pain and suffering. When we're thinking about intensive medical care at the end of life, we also must consider the emotionally burdensome nature of much of that treatment, because it interferes with human functioning. It makes it difficult for us to speak, or impossible for us to speak. It dulls our sensory capacities. It makes it impossible for us to hug people. All of those can be significantly burdensome emotionally. And then finally, there is the cost of treatment. As we've already mentioned, sometimes medical treatment at the end of life causes families to go into bankruptcy. That's a burden that is surely relevant when we think about this balance of benefits and burdens. So let's return to the bottom line here. Sometimes it's morally permissible to refuse or not provide a life-sustaining treatment because we are recognizing in so doing the inevitability of death, and that biological life is not an absolute good. It's a recognition of the possible relevance of quality of life considerations. Sometimes our lives are of such low quality that extending them is no benefit to us. And finally, it's a recognition that many medical treatments, especially life-sustaining treatments, are often more burdensome to us than beneficial. For that reason, it's appropriate to not offer them or to refuse them. This concludes then our initial presentation of the issues related to medical care at the end of life. Hopefully this has stimulated your curiosity and your interest in the rest of the material we'll be looking at throughout this unit.